So it's 2 o'clock and I'd love to say welcome to everyone that's already joined. My name's Sarah Bates. I'm a neonatal consultant in Swindon. I'm going to be chairing today's webinar. We're probably going to give another 1 or 2 minutes just for the final people to join us. We've got a very big lobby. We're trying to admit everyone at once. So welcome to everyone that's already joined. We'll give it maybe 1 or 2 more minutes and then we'll kick off. So I think we'll kick off if that's okay. I can still see there are still a lot of people joining us. So hopefully you'll all be joining us as we start this afternoon's webinar. So a huge welcome to everyone. It's amazing to see so many people joining. What a huge attendance list. So thank you to you all for coming to this afternoon's NNAP webinar. My name's Sarah Bates. I'm a neonatal consultant in a local neonatal unit in Swindon and in Wiltshire. I used to be the quality lead for BAPM and I still work on perinatal optimisation for BAPM and also work with the wonderful NNAP team as well. So I'm going to be chairing today's webinar and we'll kick off with some housekeeping points to start with. So all of the attendees at the webinar will have their cameras and mics disabled, but we will enable them at the end for the Q&A session. If you do have any questions, please post them in the chat. You'll notice we don't have the Q&A function, so please post your questions in the chat. I'll keep an eye on the questions as we go through, and then when we get to the end, we've got quite a bit of time at the end for a Q&A session. So do pop your questions in the chat as we go, please. This webinar is being recorded and transcribed, and we will post this on the RCPCH website with a link sent out in the newsletter next week. So do let your colleagues know if you've seen some really useful content in today's webinar to check out the link when it's circulated next week. If we run out of time for questions, hopefully not, we're going to try and keep the speakers to time, then do email the project team at NNAP. They are brilliant. I email them far too frequently with random questions, and I just think we should really pay credit to the team at NNAP. They are just brilliant. They work so hard and they always respond to the queries, no matter how small. And they never manage to tell me that it's a stupid question. They're always very polite and kind. So do email the team if you have questions afterwards. So without further ado, I think we'll move forward to our first speaker. It's quite hard to introduce the wonderful Sam Oddie. It's a bit hard to know where to start. Sam is a consultant neonatologist in Bradford. He has been the clinical lead for the National Neonatal Audit project for ever, and he's done an incredible job in showing the data that drives forward quality improvement across neonatal care in the UK. He also does a huge amount of work for BAPM, most notably and recently being the BAPM data lead. So I will pass you over to Sam.
Well, thank you, Sarah. daunting introduction. So hopefully with a few more clicks, I'll have succeeded in sharing some slides. Just got a little bit of fun going on here.
You can see the slides, just not quite in slideshow.
Yeah, but not in maximal view though. Eh? Here we go. How about that?
That's it. Duplicate slideshow, and then we'll be
Yeah.
there.
Fantastic. Excellent. So thanks very much, all of you, for being here. So what I'm intending to do today is to give you a little bit of a feeling for what findings we have shown in the report, and a bit of a feel for the recommendations, the national state of the nation recommendations that we've made. I want to show you some disparities, some of the disparities work that we've done. And what I'm hoping is by the end of the talk, you'll have a feel for some of the outputs that we have created. So, of course, the report, but also the posters, which I hope many of you will be familiar with, and NNAP Online, where the annual results for NNAP live. And I'm going to show you an example of that in due course. Separately, Humfrey's going to talk about what we call the PAD and the RAD, so I'm going to let him talk about that. But also I want to point out to you the existence of the so-called Your Baby's Care and some published papers. I'll probably touch on those. But firstly, I want to say that the project wouldn't exist without the partnership that we have with Parents and Bliss. I think that the photographs represent something that is kind of fundamentally motivating, probably for everybody on this call, that caring for babies is kind of what it's all about. The data might be dry, but it hopefully relates to real people's experience. And we certainly find the photographs collected by Georgia in the best ever photo collaboration we've had with families, run by Georgia this year. So, and we're trying to use these liberally because it feels important to us. So we have this output, Your Baby's Care, which is a bit of a sense of what the report's about for families. We'll be sending you some paper copies of that, but we appreciate that you're mostly going to use that in your Padlets and in your websites and in your parent-facing electronic communication. And so please do make use of that and collaborate with us if you want the QR code in some different form, or you want to use it differently, please let us know, see if we can help. I'd love to do that. So this webinar is really mostly about the report and about using the data. And this is an example of some of the posters which we hope are widely they're widely used. So I'm going to try to canter through like far too many slides. And firstly, I want to talk about outcomes in neonatal care. Everybody knows how we measure mortality. This is admitted babies of less than 32 weeks, so 24 to 31 weeks inclusive. And you can see from the graph, the blue line, horizontal, no change in mortality, with essentially no missing data. Not a massive surprise to me, to be honest. What I think is important to bear in mind, though, is that mortality is dynamic. In networks, I hope it's not an exaggeration to say that there has been change within networks over time. And I know that individual networks take this kind of mortality reporting very seriously. Because mortality is such an important outcome, and because there is such a lot of variation between different neonatal networks, so I hope it's reasonably obvious here that the network with the highest mortality has mortality of twice the mortality with the network with the lowest mortality. So there is important network level variation, and mortality is attributed to network, as you know. So unsurprisingly, NNAP, the group that makes the recommendations, wanted to make recommendations about this. And NNAP have said that neonatal networks should know their mortality data and develop, if their rates are higher than expected, develop locally prioritized quality improvement plans, and that they should concentrate on what the Americans would call potentially better practices. So structure, staffing, clinical governance, and clinical practices. And that is exactly the same recommendation we made in the 2023 report, and that's not an accident. The second recommendation is that neonatal networks should work with a unit to undertake reviews of mortality in accordance with the forthcoming BAPM framework, and that shared learning should actually inform network governance, but importantly, unit level clinical practice. So one more thing about mortality, because a lot of neonatal colleagues are very interested in the babies at 22 weeks gestation, and NNAP has a unique window on these. I hope that you can see in the first column to the right of the dates. So this one where my mouse is hopefully hovering. I'm not sure which one's going. There we go. The number of babies admitted at 22 weeks gestational age went up very quickly after the guidance changed, and is now static. So the number of admissions 104, 112, 108. So no longer climbing. The mortality proportion is about the same as it ever was. So there are more survivors in 24 than there were in 2018, but the number of survivors is not climbing statistically significantly. And for the 23-week babies, you see something slightly different, which is perhaps not so surprising. So I'm going to talk about outcomes, bronchopulmonary dysplasia. On the right-hand side here, the right-hand graph showing that the proportion of babies who get BPD has not changed over time. It's possibly going up a little bit. And the reference down below, a group associated with NNAP have tried to understand a little bit about what's changing. And thank you to the team who wrote that paper, published in the middle of the year. The left-hand graph is BPD or death, because these are to some extent competing outcomes. What is very striking is the extent to which BPD, the outcome, and the left-hand graph varies by centre. So these are a form of graph we call a caterpillar plot, and I hope that you can see that on the left-hand graph, there are a load of dots, and each dot's got a vertical line associated with it. Depending on what colour the dot on the line are, the pink ones are neonatal intensive care units, the blue ones are local neonatal units, and the grey ones are special care units. Now, it's not a surprise if you think about it that the rates of BPD are higher in neonatal intensive care units in general. They're mostly on the right-hand side of this graph, because typically they will look after the less mature babies of less than 32 weeks. So it's not really a surprise that local neonatal units have lower rates of BPD. The right-hand graph takes that into account. And so this is adjusted for gestation and a variety of other clinical factors. And this produces what we call a treatment effect. And I hope it's visually obvious that the pink dots are more evenly distributed across the range. So there are, for example, a neonatal intensive care unit here, where if you're cared for in that neonatal intensive care unit, in 2024 at least, you're at more than 10% lower chance of getting BPD than the average. And there are similarly neonatal intensive care units where being looked after in that unit seems to be associated with an increased risk of developing BPD. And the units are attributed to the unit of birth. So this is adjusted, and we hope that this is helpful to units in thinking about their own BPD rates. But what can you do about BPD? Well, one of the things that you can do is think about non-invasive breathing support, also, as I would perhaps oversimplify it to be, use of primary CPAP. Now, we know across the country that rates of babies only treated with non-invasive breathing support in the first 7 days of life have increased a little bit. Not a huge change, but probably the sort of pace of change one might expect. So that's a little bit more adherence with national guidance. I think that's encouraging. It's better than the opposite. And this is the same sort of figure that I've just shown you for BPD rates, showing that neonatal units vary hugely in their willingness to avoid ventilating babies of less than 32 weeks. Same sort of effect with the neonatal intensive care units, a little bit less likely to do CPAP only, and the blue and grey units, local neonatal special care units, perhaps a bit more likely to get away with that. Probably explained by the gestational age mix. But in the right-hand panel, this is adjusted for gestation. And here, I think you can see that there are neonatal intensive care units that have a style of practice that makes them much more likely on the left-hand side to avoid ventilation. And there are neonatal intensive care units that are much more likely to end up ventilating their babies. And these are big effect sizes, so more than 20% more likely. So that tells us that practice is different. That doesn't mean it's worse, it just tells us that practice is different. And we hope that being identified compared to one's peers is helpful in terms of thinking about how one might wish to practice in the future. So how can you identify where your unit is on that? Well, the way to do that is to look at NNAP online, and there'll be many of you with more than one screen, and so you might even be Googling NNAP online as we speak, which is fine. So if you were to go to the front page of NNAP online, you then want to go to the unit graphs, this tab here, and that will take you to a figure that looks like this. And again, this is bronchopulmonary dysplasia, and this is for Bradford, showing that we have our slightly sort of mid-range, perhaps for neonatal units. But we might be interested in our non-invasive breathing support, and it seems we have a slightly different. It's slightly different to how it was before. So this is adjusted for gestation. So we hope that this is helpful. So this is not adjusted. This is the treatment effect. That's what I said. It wasn't the first one. My apologies. So we hope, therefore, and make a suggested action for quality improvement, that neonatal networks might want to look at the variation in use of non-invasive ventilation across their units, trying to identify and implement quality improvement opportunities through shared best practice. So this is not a recommendation, it's an action for quality improvement. So another outcome, super important, that we are very invested in is a late onset bloodstream infection. And this, as we measure it, is the proportion of babies who are born at less than 32 weeks gestation, who have a late onset bloodstream infection with a clearly pathogenic organism. And using the 2024 definitions retroactively, you can see that the proportion is about 1 in 20. And there's maybe a bit of an increase this year, but it's probably broadly about the same. Lots of centre level variation, with in general neonatal intensive care units having higher rates of infection than local neonatal units. If you adjust for gestation, you see that there are units, in this one, the yellow units are the neonatal intensive care units that do surgery. You can see that they're associated with, that they have there are surgical NICUs that have high and very low treatment effects, suggesting that it's not really about unit type that influences the risk of infection, and it's that there really are probably potentially better practices. If you were to ask me what they were, I'd love to know. Maybe you could write to me. That'd be most helpful to my own unit. So I'm not going to spend much time talking about NEC. I think perhaps if you're a very optimistic person, you might think this is on the decline. I think the red line is more important here. The red line is the proportion of missing data, which is still non-trivial. And we're aware that we've got a very large number of units writing to us this year in response to our survey, telling us that they had assured the quality of their NEC data, which we're delighted about, and thank you for doing that. I think there's still some way to go before we can be really confident in this measurement, but nonetheless, we hope that the following caterpillar plots, which I'm busy not showing you, the caterpillar plots which you can find on NNAP online, may be helpful to you in terms of understanding whether your NEC rate is high. In terms of what one does about NEC, so clearly breast milk is highly protective, and we have various measures of breast milk use. Here I'm showing you the proportion of babies of less than 34 weeks who are receiving any breast milk on day 14 of life by neonatal unit. And then the left-hand panel, it's any maternal milk. And one of the benefits, I hope, the way we're reporting this year is in the right-hand panel. You can see that that's exclusive maternal milk feeding. And look at the difference in the proportion there. So you're much less likely to get exclusive breast milk feeding. And I think very striking variation even in this measure by unit level, but I'm not talking too much about that. But I'm going to keep going on about outcomes. So we want to measure cystic PVL as one example of preterm brain injury. And there is quite a high level of apparent variation in this. We're particularly, I'm particularly struck that rates of post-hemorrhagic ventricular dilatation, another form of brain injury. There's a parallel variation here, but the key thing about this figure on the left-hand figure here is I think probably the underlying rate is too high. By too high, I think it may not be accurate. And so I suggest, and we're delighted to enter conversation correspondence about this, I suggest that it may be that we are not yet fully accurately using the definitions which exist in Badger for defining what exactly PHVD is. I'd suggest that the rate of 4.2% is a little bit higher than we might expect. One of the problems with measuring preterm brain injury has been missing data. So this is the grey points in this figure represent the proportions of missing data for the 2023 data, and the coloured triangles show. So, for example, for my own network, find it here. We had about 20% missing rate. No, that's the northern region. That better not do that. So Yorkshire and Humber, we had about 9% missing data rate to come down to very low levels. So we should be pleased about that. And you can see that most neonatal networks have very much improved their missing data rate this year. But there are still several networks where it's well over 10%. And that does seem quite concerning. And we could talk more about why that might be. There are some recommendations that flow from this because everybody recognizes that there's a real importance in reducing preterm brain injury. It's about half of infant brain injury. There's a national ambition to halve the amount of brain injury. And so if we're not describing preterm brain injury properly, then we've got a significant problem. So the recommendation that NNAP makes is that the NHS England and the health departments in developed nations should issue clear guidance to neonatal services around the correct reporting of preterm brain injury, including PHVD. And secondly, there's a recommendation that NHS England and associated health departments should develop a mandatory NHS neonatal information standard to ensure that clinical reporting systems are interoperable and ensuring robust and data collection. Because we want to measure this neonatal outcome, but indeed all neonatal care process and outcomes. Optimization, so making the babies as well as possible in the immediate perinatal period. If we think about the proportion of babies who got all the aspects of that for which they were eligible, it's still low. Okay, so only 1 in 5 babies gets all the optimization measures that they would be eligible for. So if you're a pessimistic person, I guess you could find that depressing, but I would suggest there's a steady increase, and this is good. And if we look at the individual elements of optimization, there's more news, and it's generally good. It's generally good. Antenatal steroids is clearly the best treatment in neonatal care, and I try not to be frustrated about the fact that neonatal staff don't give it. So it's given, of course, by midwives and obstetricians. Antenatal steroids, so our measure is the proportion of babies of less than 34 weeks who get a complete course of antenatal steroids by neonatal unit. And on the face of it, when you look at this figure, it would appear there's quite a lot of centre level variation. If you want to read more about antenatal steroids, in particular what I'm about to say, I really recommend Dr. Pettinger's excellent article on this subject. You'll be able to, you can just Google that easily, but you can access it through us directly or through the webinar slides. Unfortunately, this variation that I've just described to you is, I think, undermined by a lack of clarity about what a complete course of antenatal steroids means. It turns out that very commonly perinatal teams are giving antenatal steroids 12 hours apart so doses of typically doses of betamethasone 12 hours apart, instead of, as recommended in the RCOG and ACOG guidance, 24 hours apart. So what the figure shows you is this dashed line shows you the proportion of antenatal steroid courses which are too short compared to the guidance is about half. So about half of antenatal steroid courses are shorter than recommended. Now, does that matter? It may matter because it has been associated with an increase in adverse outcomes. One can argue about that, but there is a little bit of evidence of that. Importantly, the approach of trying to squeeze 2 doses in case the woman delivers quickly has not been shown to be beneficial. There's no evidence of benefit, and people have tried to look. So I think there's plenty of grounds for concern here. Our colleagues, and again, you can see from the figure that this varies by region. So some regions do this more than others. Our colleagues in the northern region who drew our attention to this are very good at not giving short courses of antenatal steroids, short-end courses of antenatal steroids. Whereas that varies across the piece, and that will undermine the measurement and explain some of the variation that we see at unit and also at network level. So we're going to address this by reporting it differently. In better news, the practice of deferred cord clamping continues to go up, so that's very exciting. It's delightful to see how quickly as a community we've taken that on. So I think that is brilliant, and we're very pleased to see negligible missing data. Nearly 3/4 of babies across the country getting deferred cord clamping at or after a minute. Also very pleasing to me is to see how the regional variation, which was quite wide in the past, is narrowing down. So we're all getting more similar. What I will be fascinated to see in the coming years is whether that continues to increase, or maybe it'll just level off. And that's I'm making a judgment about what's optimal, because I don't think we know what the optimal is in this context. And again, there's a complicated conversation to have about that. But good news around deferred cord clamping for sure. Not everyone finds this exciting, but breast milk feeding is clearly part of the solution. So again, in this pair of figures, we have the proportion of babies. This is within the first couple of days of life. So this is seen as an optimization measure. And a steady increase in the proportion of babies in the left-hand figure who are getting any breast milk in the first day, or on the first day or the second day of life. So 2/3 of babies across the country. Where we're thinking about exclusivity, you can see that it's significantly lower. So it's about 20% lower. So a lot of babies less than 34 weeks getting a mixture of mother's milk and formula. That doesn't mean that that's necessarily wrong for some babies, but it's interesting how exclusivity varies. And you can see your unit level exclusivity data on an NNAP online. Very striking, I think, how much variation there is. There are neonatal intensive care units in pink on the right-hand side of the left-hand figure that can apparently give maternal milk to 2/3 of their babies. So 9 out of 10 of their babies. And then there are neonatal intensive care units who presumably got a similar population where they can only do that four babies out of 10. So a really quite striking unit level variation. And if we look at exclusivity, you see the same variation. So I think there's stuff we can learn from people who do that the best. And NNAP makes a recommendation that neonatal networks and LMNSs in England, local maternity neonatal system, should ask their constituent units with below average rates of breast milk feeding by day 2 to understand the reasons for variation and co-design targeted quality improvement programs targeting this process to try to improve rates of breast milk feeding in the first 2 days. So we are continuing our gradual increase in the proportion of babies who are kept warm through stabilization. So a continued gradual improvement. and that it's pleasing to see. And of course, this is a proxy measure for the quality of stabilization of these little babies. And I'm going to keep going. So the proportion of babies born in the network, born in a unit with an associated neonatal care unit, it's gradually possibly creeping up, but looks quite flat in recent years, really, doesn't it? So I think the key thing, this is something the networks are really very engaged in, and I submit that there is evidence that this is dynamic, that this can vary. Look at Wales, for example. There are other examples of neonatal networks where this has changed. The point I would make about interpreting this data is that you need at least a mental map, or perhaps you need an actual map. But the networks are not all the same. They don't have the same challenges. Some neonatal networks have far more NICUs than others, and that potentially explains their positions in some of these plots. Some of the networks are much bigger than others. They have different challenges, and it would be an oversimplification to say anything else. Antenatal magnesium sulfate is something that I think we can be really proud as a perinatal community to have rolled out to 8.5 babies out of 10. So 17 babies out of 20. It's just fantastic. If you were a slightly depressive person, it'd be possible to say, oh, but it hasn't changed, it's stopped improving. But the biggest challenge in quality improvement is sustaining the change. And here we go, we adopted this treatment, it hasn't dropped off. And I think that's a thing to be, and one can look at center level variation, but I'm not going to show you the data. So we make a national recommendation around optimization that, and it's actually the same recommendation we made in the 2023 data. So we've created this restricted access dashboard. A neonatal network should ensure that constituent units are using the RAD to regularly review their rates of optimal perinatal care delivery, identifying instances of non-adherence and implementing quality improvement activities in response to them. So in my unit, for example, we review all the preterm deliveries, we think about optimization, where there's a missed opportunity for one or other, we would then take appropriate actions, and indeed do, and have a log and all the rest of it. So parental partnership and care, pretty a key concept. I need to speed up a little bit, I think. Parental consultation is a measure for which NNAP is well known. 19 babies out of 20 the parents are spoken to within 24 hours of admission. So that's not a very high bar. I'm going to keep going. Oh my goodness. To your follow-up, this is something which is slowly improving, but I particularly wanted to show you the center level variation on the right-hand graph here. There are quite a lot of neonatal units that are getting more than 90 or 95% follow-up rates. We're going to hear from an example shortly, but this feels like we ought to be rewarding these units by reporting the rates of severe disability, and we're taking steps in that direction. So I will get off relatively soon, I promise. On-time screening for retinopathy of prematurity, we're seeing convergence in this. So the neonatal, a lot of variation, and that is converging. There were neonatal units and networks that were not adopting this relatively new guidance, and I see that's changing, which is very gratifying. And neonatal nurse staffing as a whole talk in itself. I'm going to skip across that. But I did want to spend some time talking about equity in neonatal care delivery. And in particular, to point those of you to a paper recently published in BMJ Pediatrics Open, again, but written by the excellent Dr. Pettinger. And the objective here was to understand whether perinatal care delivery in England and Wales varied by socioeconomic deprivation. It does. But also, very surprisingly, to some extent to me, it varies by ethnicity. And I'm going to show you, not going to show you the data from the paper. In the paper, what we did was we took into account confounding variables. So, for example, babies of Black ethnicity in neonatal care in the United Kingdom are more preterm than babies of white ethnicity. And so it's very important to take into account confounding variables such as that when trying to establish if there are associations with deprivation and ethnicity. And the bottom line is that people, and we're going to concentrate particularly on ethnicity in this context, that the care that we as a neonatal community deliver to the population is associated with ethnicity in ways that are really quite disappointing. By all means, read the paper. We'll look forward to conversations about that. What I'm going to show you now is not that data, but it's the raw data, unadjusted. And we've done this deliberately. Hopefully, it's the right decision. So this is the proportion about the measure of parental consultation, and you can see that parental consultation takes place in 19 out of 20 white families, but in a statistically significantly important lower number in Black families, and similarly in Asian families. So there's a difference by ethnicity. I'm going to suggest that you don't take too much notice of the columns on the right-hand side for reasons that are too complicated to immediately go into in this talk. So a bit of a difference in consultation, which is disappointing, I think probably we would all agree. So what about some practical potential implication or follow through from that? So this is the use of breast milk in the first couple of days of life. And you can see that Black babies, or babies to whom we attribute a Black ethnicity, are significantly less likely to get breast milk in the first couple of days of life. And you see that also for Asian infants. It's a bit disappointing. Good news, however, the babies of Asian and Black ethnicity more likely to receiving breast milk by day 14, or perhaps we could say that families of white ethnicity are not as good at producing or supplying breast milk for their babies. But important considerations, important differences here. And we see this also at discharge. So this effect is more striking, if anything, at discharge. So Black babies more likely to go home getting at least some breast milk. Asian babies more likely than white babies. Quite a striking ethnicity grading. So perhaps some of you, this would have been known to some of you, some of these findings are not a surprise to me. But what really was a surprise to me was the fact that if you look at the measure of deferred cord clamping, less than 34 weeks gestation, the Black babies are less likely to receive deferred cord clamping in unadjusted data. No difference for the Asian babies. So very striking. So often when I've discussed this with doctors, they've got a ready explanation as to how this effect might be mediated. It might not be true, actually, but I'm not going to tell you what they suggest. So I hear that potential explanation. But that doesn't explain why Black babies are more likely to be admitted to cold. And that's what you see here. So this is our measure of temperature, and it's more likely that Black babies are admitted to cold. So there's a recommendation, as you'd expect, to go with this. So neonatal networks and LMNSs are tasked to work with their neonatal units. Firstly, to ensure that staff get appropriate and consistent training to confidently ask the families about their ethnicity. Because if we've identified differences in care by ethnicity, we won't sort out that inequity unless we describe the what epidemiologically we call an exposure with the ethnicity appropriately. So it's key that we get that right. And then the second thing is that neonatal units and teams should use the NNAP dashboard to review, firstly, how well they do breast milk or deferred cord clamping or temperature compared to the national average. So firstly, me and my team in Bradford need to compare ourselves to the national average. And then, and only then, should we then compare the local ethnicity figures, which will be on NNAP, on the RAD, which Humfrey's going to talk about later in the week. It's important that you do it that way around. Firstly, compare to the national average, and then compare by ethnicity. And then, if there are differences, clearly, the recommendation is to do something about them, and subsequently, with families, co-design quality improvement activities that actually address those causes. So I've given you lots of stuff. What I hope you're doing is furiously looking at an NNAP online. There's a lot more material in the what we call the extended analysis report, and you can QR code this, or you can just Google it. You'll find it on the RCPCH NNAP website. And I hope this would be helpful to you. And we're always interested to correspond about what we found. So final slide, I promise. Where to next? So the contract's been extended. It's always about the money, isn't it? So we've got a contract running up to March 27. There'll be a tender process, and I don't think it'd be a surprise if the college bid to run this program again. We would love to do that. We recognise the challenge of trust-wide EPRs and how they interact with the Badger system where we get our data from. We're working and doing what we can around that. So that's an important element of work for us. Parental partnership in care, we strongly recognise the value of this and strong desires to measure it effectively. We've undertaken a piece of work which is actually stepping back and just trying to work out exactly what we mean by that expression. So or more importantly, what do parents understand by parental partnership of care? What do parents and staff understand? And then trying to think about potential new measures thereof. And that work has started. We're very keen to work with NMPA, and actually Kirstin's going to talk about that, so I'm not going to talk about that now. Bloodstream infection data. We know that we can get that in. We're quite well advanced, but still haven't yet quite completed a linkage program with UK HSA, so the United Kingdom Health Surveillance Agency, I think that's what it stands for. So they know about all the positive blood cultures. So if they told us and we told them some stuff, we could mutually advantage one another. We want to explore reporting some of our measures differently. I've mentioned some of that already. We want to explore potential other things such as use of probiotics. We want to describe for neonatal units with high rates of follow-up what the developmental outcomes of the babies are. And we want to further develop the equity reporting, and some of that will be coming this week. So with that, I'm going to get off and attempt to unshare, which is always, there we go. I'm sorry if I've gone over time, team.
You haven't actually, Sam. You finished 7 minutes early.
Never again.
Which is brilliant. I know we have got quite a lot of time at the end for questions. There's one question in the chat related to your talk. Would you like to take it now, or would you like to take it at the end, Sam?
I'm always keen to encourage more questions. So I'm happy to take a question if there's time, Chair.
Yeah, absolutely. So why don't we take this question now, but note from Sam to everyone, please put some more questions in the chat for our Q&A at the end. So Belinda, who's from Sherwood Forest, has asked, why is donor milk not included in the NNAP data? And is there any scope to have this included? I've definitely got some thoughts, but I'll let you answer that, Sam.
And so there's a broad answer to that. So we probably, I suspect, I'm not quite sure what Sarah's going to say, but my own view is that donor is a useful bridge to maternal milk in some situations. But the bottom line is the reason we haven't included donor milk is because that's not what our service users told us that we should do. So when we develop these measures, we develop them very specifically around what the various kind of interest groups think we ought to measure. And so people fairly frequently, to be honest, approach us and say, oh, you should do this. And having chosen to do something, we would then need quite a lot of persuasion to change. I'm not at all persuaded that donor milk, it might be a separate measure, but I don't think we should include a baby in the numerator because they've been exposed to donor milk. I suppose it depends a bit if you think that formula is the thing to avoid at all costs. But I think it's more that maternal milk is a thing to use wherever you can.
Thanks very much, Sam. Yeah, I think my thoughts would be fairly similar there. I think the importance of the early breast milk measure is around getting that early breast milk supply up and running and really engaging with our perinatal partners, our midwifery colleagues, to support women to express as early as possible. And I think it's really interesting to think about the access to donor breast milk across the country, because it definitely isn't equitable. But I'm also I also agree with your comment around it being a really useful bridge, but the maternal breast milk being the holy grail. And if anyone is working on their maternal breast milk, can I signpost you back to the original BAPM MBM toolkits, which still have got quite a few useful hints and tips for you all. Would you like to take one more question, Sam, or do you want to leave the remaining questions to the end?
Let's. I fear we'll get locked into a. Let's because we've got some excellent other speakers. Let's let them, and then we can all join together. How about that?
Excellent. Let's do that. There's lots of questions firing into the chat, so I will keep those for the end. And without further ado, we will move forward to Kirstin. So I'm really pleased to be able to introduce Kirstin, who is an advanced neonatal nurse practitioner by background. She's a PhD student at the University of Leicester, researching the healthcare needs of children in the first 2 years of life. But for the past 5 years, she's been the Neonatal Clinical Fellow for the National Maternity and Perinatal Audit, NMPA. And she's been providing a neonatal clinical perspective to that audit, and she's going to talk to us about the hugely exciting potential link between NMPA and NNAP. Over to you, Kirstin.
Lovely, thanks, Sarah. So hopefully my slides are sharing okay.
All looking perfect, Kirstin.
Lovely, thank you. Okay, so I'm going to give you a little brief whistle-stop tour of the National Maternity and Perinatal Audit report. So we are a national audit of maternity data commissioned by the Healthcare Quality Improvement Partnership. We're a collaboration between the London School of Hygiene and Tropical Medicine, Royal College of Paediatrics and Child Health, the Royal College of Midwives, and the Royal College of Obs and Gynae. We work together to produce results for all births that take place in NHS hospitals across England, Scotland and Wales. We use linked data that are routinely entered, routinely extracted into maternity services data sets, and information about hospital admissions for mums and babies. Now, we've had a bit of a gap between our reports. We were waiting on an updated maternity services dataset from NHS England. So our previous report that we published was on births in 2018 and 19. And we've just, in September, we published our State of the Nation on births in 2023. So this report covered births for just under 600,000 women who gave birth in 2023 across England, Scotland, Wales. You can see the across the trusts and boards and the numbers there on the screen. So I will just move forward if my slides will change. Oh. Okay, so there we go. So for the first time in the period between publishing reports, we actually revised and renewed our measures. And so for the first time, we're reporting a measure of late booking. So this is the number of women and birthing people who attended their first appointment, their booking appointment with their midwife at or after 10 weeks of gestation. And around a quarter of women were booking late in the data. We've also, we've previously reported information on preterm birth, and we see that the results, preterm birth rates are down from our previous reports. But this is the first time that we're reporting the difference between spontaneous preterm birth, a preterm birth that is spontaneous in onset and that which is iatrogenic or clinician recommended. So this is the first time we're publishing this. We will have more data on this going forward. So there's not really an awful lot that we can say about kind of the differences in that at this stage. When we look at mode of birth, we see that there is a reduction in vaginal birth without the use of instruments. In our previous reports, this rate has been around 60%, and in 2023, the rate of vaginal birth without instruments was just under 50%. The rate of use of instruments has broadly stayed the same. So vaginal birth with the use of instruments, around 11% of births, and the difference between Von-Teuse and forceps has remained broadly similar. So we see that the change in mode of birth is predominantly in unplanned and planned caesarean births. We've also seen an increase in induction of labour from our previous reports, and we have an induction of labour report snapshot audit coming out later on this year. When we look at outcomes for women of birthing people, a major bleed following birth, a postpartum hemorrhage of 1,500 mils or more, has been these rates have increased from our previous reports. This may be due to changes in around how blood loss is measured. We still see in the data that blood loss volumes are being estimated more than measured, but this is changing. Third and fourth degree perineal tears and episiotomy have remained broadly similar across our reports, but I'm pleased to say that babies born small for gestational age at or after their estimated due date, so 40 weeks of gestation, has steadily reduced. So we reported this was more than 40% in our first report, more than 50% in our first report back in for births that occurred in 2015-16, and this has fallen each report until 2023. So we hope that this is a trend that we will see continue. When looking at measures of care of the baby, APGAR score of less than 7 at 5 minutes, just under 1.5%, and this is slightly up from our previous reports of 1.1 to 1.2%, but we have adjusted the definition of this measure to, previously we reported this for term babies only, so those born at or after 37 weeks, and we have adjusted this to include the late pretermers, so this now includes babies born from 34 weeks. So that might explain some of the difference in the rate that we see. Breast milk feeding at first feed, Sam's touched on this in his presentation. We still see that it's less than 3/4 of babies receive breast milk at their first feed, and we're unable to report breast milk feeding rates at discharge, which we had done previously. Breast milk feeding at first feed, we're unsure how meaningful this is as a measure for ongoing breast milk feeding. So there were infant feeding surveys that were published every 5 years from the 70s until 2010, and the government have actually last year commissioned Ipsos to produce another infant feeding survey. So hopefully this will give us some information about what the longer term feeding patterns are in the UK, because UNICEF report that we have some of the lowest breast milk feeding rates in the world. So does reporting breast milk at the first feed have any impact on the ongoing feeding journey? And similarly with skin to skin, the rates were static in our previous reports at around 80% of babies receiving skin to skin within the first hour. And again, this change that we see here down to 73.4% may be due to an adjustment in gestational age, because we're now reporting this for babies from 34 weeks. The absolute range, where we look at the variation between units, the absolute range in the difference was from as low as 9% of babies up to 96% of babies. And we're wondering if this is perhaps around the definition and what constitutes skin to skin within the first hour. So the UNICEF definition of skin to skin is for as soon as possible following birth and for as long as mum and baby want, or until at least after the first feed. Now in the maternity services data set, that definition has been slightly adjusted to skin within the first hour. So it's possible that there's some uncertainty around what constitutes meaningful skin to skin, and that's why we see such a variation in the rates between units. So when we looked at making our recommendations, the first recommendation that we wanted to make was to government health departments to look at local and national initiatives and campaigns targeted at timely rates of pregnancy booking. So when women and birthing people book later than 10 weeks for their with their midwife, their first appointment with the midwife, that can impact their dating scan, information about their pregnancy, their anomaly scan, their plans for ongoing pregnancy management, and labour and birth. And these can be impacted, late booking can be impacted by aspects such as maternal age, deprivation, their ethnicity, and their previous experiences of pregnancy and birth. So we want to see initiatives to target the reasons behind this and improve those rates. With the changes that we see in mode of birth, so the increase in operative births and a decrease in vaginal births without the use of instruments, and increase in induction, this has an impact on services. So we would like to see government health departments take these changes into consideration and anticipate and respond with appropriate allocation of resources such as workforce, maternity bed, cot availability, obstetric theatre capacity, and finances, so that we can really optimise the options available to women and birthing people for when, where and how they choose to give birth. And we would like to see maternity care commissioners and networks use this unexplained variation that we see in the rates between providers to understand and use their local information to understand why these differences happen, and to target improvements for service provision and clinical practice. And the following two recommendations are rather data-driven. So these are targeted at the digital teams, which are within the government network, so formerly NHS Digital, and the Devolved Nations equivalents, and those who design, develop and operate these national IT and data services, to review the data definitions and descriptions and their clinical applications, so that we can objectively measure and record all volumes of blood loss, so that we can improve the reporting of information around particularly PPH, and develop meaningful and consistent measures of skin to skin, and establishing and supporting breast milk feeding beyond the first feed. And we would like to see the maternity data controllers and software developers incorporate into the updated versions of the data sets changes in the definitions and the way that these data are recorded, so that we can optimize the data quality without increasing the burden on clinical staff for data entry. So that's really a whistle-stop tour of our report. You can access the report online. I've got the link at the end of this presentation, so you can look up your own unit online, look at our results and compare with units that are of a similar size and similar demographic. So now I'm going to move on and talk about the linkage that we are hoping to achieve with NNAP. So we can report, we're hoping to report better neonatal outcomes of maternity care. So this is a collaboration that Sam and I have been working on for quite some time with the wider NNAP and NMPA team, and then wider input from others that we'll talk about as I go through. But this has been a long time in the making, and so we are edging slowly forward, and we're really excited to share this with you. So the next slide, it's very busy. I'm not expecting you to read all of these all of this information, but basically this is just to show you what we're trying to bring together. So the top half of the screen, or the sort of slightly lighter blue, are the maternity data sets that the NMPA use. So we have maternity data, mortality data, hospital admission information. We want to bring all of this maternity data together with the data that is input at a neonatal unit level and flows into the neonatal audit programme. So this really we're hoping will benefit not only maternity and neonatal services, but will feed into some of the national initiatives as well. Some of the conversations that we've been having have been influenced by the reviews that have been undertaken, the independent investigation reviews, but also the national our targets, such as the long-term plan, better births, avoiding term admissions, avoiding brain injury in childbirth. And so we feel that bringing these data together can really benefit and inform these national initiatives. So the reason to bring them together is to enrich the data of both maternity and neonatal reporting, so that we can report measures that are meaningful, that are available and routinely collected. We're really mindful of not adding to the data burden that already exists, and so that we can report robust neonatal outcomes of maternity and neonatal services in collaboration. So what you can see here on the screen is just examples of measures that can be reported. It's not exhaustive or definitive, and we are ever adding and changing what we think that we can report. So if anybody has any feedback, we would be interested to hear. But we look at, we've got measures here that could be reported by the maternity audit and by neonatal audit programme. So I think it's really important to remember that the babies that are reported that are presented in the neonatal audit programme are those that are admitted to neonatal care. And so there are a number of babies who have neonatal input or who would come under some of these measures who are not admitted to neonatal care. And so we need to make sure that they're picked up somewhere, because at the moment there are some who aren't being measured or reported on anywhere, and that the maternity audit, the NMPA, is really positioned well to report on those babies. And Sam's already mentioned antenatal steroids in particular, and deferred cord clamping, and especially with those two. There will be a number of babies for whom the antenatal steroids in particular, for whom their mothers receive steroids but in the maternity services, and they then go on to either be born not preterm or not preterm enough to require neonatal admission. So we'd like to really capture those babies there. So this has been a coming together of lots of different bodies. We've had to have, we've gained support from the national clinical directors at NHS England. We've spoken to our colleagues in NHS Scotland and NHS Wales, and we've really got the backing, and so driving this forward. We're at the point where we are applying for data approvals with NHS England, and starting the conversations with Scotland and Wales, and particularly for NHS Scotland, because of the way the data ownership is slightly different in Scotland to England or Wales. We're going to need approvals from each board in Scotland to say that we can use their neonatal data. So that will be something that will be coming. So any colleagues in Scotland on the line, we will be looking for your support in driving this forward. And in terms of what's next for the NMPA, we have, as I said, an induction of labour snapshot audit that is due for publication in November, and then we are working on a snapshot audit of multiple births outcomes of maternity care. So how best we can incorporate the results for twins, triplets and more into the maternity report, and can we report annually outcomes for multiple births babies, and then we are working on our next State of the Nation and annual clinical report for births in 2024. So hopefully those last two, multiple births and the State of the Nation for 2024, will be published early next year. And then I've just popped here, there is our QR code for our website here, but I would encourage you at the moment to look at it on computer. We're going through a change of website provider, and at the moment looking at it on your phone, you don't always quite, it doesn't always quite work out with the best layout and such like. So if you're going to have a look at it, I would encourage you to look at it on a computer. And I think that is me done. Did I whistle through quickly enough?
Yeah, you've also finished early as well, Kirstin. Clearly my threat to pause people if you were going to be over time is working very well today. If it's okay with you, Kirstin, we might do what we did with Sam and give you time for one specific question. And there's one question here which says, question for Kirstin, in the chat from Sirana. Could the term skin to skin contact in the NMPA audit be amended to safe skin to skin, which is difficult, to emphasise the safety aspects of skin to skin, given a few significant adverse events, including death and HIE of babies who've been skin to skin.
That's really interesting. Yes, I mean, I don't disagree with that. How we would measure safe skin to skin in an audit environment, I'm not entirely sure. That would perhaps be difficult. Whether we could look at skin to skin. So the NICE guidelines actually have changed to describe skin to skin with, or to include skin to skin with someone other than the mother, if the mother's not available. So perhaps, she's been taken back to theatre, or, is for some reason isn't available, or chooses not to have skin to skin with the baby, if skin to skin occurs with somebody else. And I know certainly as an ANMP, I popped a baby in skin to skin with grandma when mum wasn't around and baby was cold, and everybody was happy with that. So and recording reasons for non-occurrence, so that perhaps if we can get a bit more detail about when skin to skin is occurring and when it's not occurring and who with, then, and perhaps if we do when we eventually achieve our NNAP linkage, that perhaps if we have skin to skin recorded, and then if we can see that there's subsequent changes, perhaps there is a sudden unexpected postnatal collapse or something similar, that then we can look at safe skin to skin. But I would think it's perhaps something to keep in the back of our mind at the moment. I don't know how we would measure safe skin to skin, but it's a good suggestion.
Yes, thanks, Kirstin. But I had similar thoughts when I read that question about actually that's quite subjective, isn't it? The kind of criteria of safe, and in many ways we only know it was unsafe when we've had some adverse events. But I think I also really support what you're saying about some of the change in the guidelines and the messaging out there around safe skin to skin and how to do it safely. We know it's beneficial. We know it's great for the preterm and the term babies. Definitely a really positive thing for encouraging breast milk. It's one of the core elements in the MBM toolkit for sure. But it's really important that we do that safely. Absolutely. There's definitely lots more questions to do. Have a good look through the chat, Kirstin, because I'm sure we'll be coming back to some more questions related to NMPA at the end.
Thank you.
But it's time to move on to our next speaker. So another lovely neonatologist from Bradford, Dr. Aishin Lok. She's also a consultant neonatologist, works with Sam in Bradford, and has got a strong interest in neurodevelopmental follow-up. And as Sam has shown you, there's some quite striking disparity across the country. My own unit is one that's really struggling with doing this really well. So I'm very excited to hear this talk. This is some work that Dr. Lok's been working on in Bradford, and has really worked at increasing the rates of high quality follow-up at 2 years of age with recording of developmental outcomes in order to inform targeted service improvement. So over to you, Aishin.
Hi, thank you. Thank you, Sarah. Can you see my slides well?
Yes, all great.
Excellent. So good afternoon, everyone. So I'm Aishin Lok. First of all, thank you for the opportunity to speak to you today, to share with you a piece of work that we've been doing in Bradford. So today I'll be talking to you about how we have moved beyond reporting 2-year outcome data to NNAP and use it as a tool to understand outcome, identify service gaps, and push for improvement in the care of our very preterm infants. Can move. 1 second, my slide's not moving. Yes. So why does 2-year data matter?
So there you go. There's a little bit of a lag, Aishin. I think it might be a lag with other people, but it's now moved forward, so all good.
Excellent. Just stop me if the slide is not moving. So why does it matter? So we know that infants born before 30 weeks are high risk of cerebral palsy, cognitive and language difficulties, and behavioral challenges. Nationally, as you have just heard about the data that has been reported, follow-up rates are around 77.9%, meaning that nearly 1 in 5 high-risk children may miss early detection of problems. In Bradford, We serve one of the most deprived population in the UK with high ethnic diversity and multiple languages spoke. These social determinants don't just complicate assessment, but they also increase vulnerability to developmental delay. That's why ensuring full and meaningful follow-up in Bradford is so important. So our QI project had 3 clear aims. As you can see here, first, we wanted to establish a consultant-led 2-year pathway, which gives continuity and ensure assessment are both timely and reliable. And secondly, to align with NICE NG 72 and NNAP requirement. This means that our local practice will meet national standards and our data can be benchmarked nationally. Finally, we wanted to build a robust data set, not just for reporting, but for actively shaping our services. And this slide shows how we use the structured QI methodology, PDSA cycles, to strengthen our follow-up program. In our first cycle, our focus was on reliability, so to tighten the process. We recognized that our outcome reporting was inconsistent. We initially used postal Parker R questionnaires, but that had poor return rates. So to address this, we digitalized the Parker R and sent secure links by text messages to families, which then improved our completion rates. We then also introduced a dedicated Bailey 3 clinic co-led by myself and the neonatal physiotherapists to provide structured and objective assessments. And finally, to have a consultant oversight on the NNAP data entry to ensure accuracy, timeliness, and consistency in what we were reporting. And in cycle 2, as you can see here, the focus shifted to integration. We knew that no single tool gave the full picture. At that point, we had, use of Bailey 3, Parker R, and we also have children who have been under the care of CDC team from the very beginning. So we also had medical notes to look at as well. And they all sort of like measure slightly different domains and look at different populations. Just to expand a little bit on that, in Bradford, the children with the more severe end of disabilities were often followed up exclusively by our CDC team, the Children Developmental Center, and missed out on the Bailey assessment. Our Bailey assessment clinic was also started only in 2023, so this is a year after the beginning of our data collection. So we made a deliberate decision to triangulate, pulling together, the Bailey results and the CDC clinical notes, so to give us a more comprehensive developmental profile and allow us to see the pattern across, cognition, language, and motor domains, as well as highlight where the children were slipping through the gaps. And you can see here, we did achieve a good follow-up rate. We had 96.9% of 2-year follow-up rate for our babies that are born less than 30 weeks. And this is above the national NNAP average. And it shows that with the right structure and leadership, it is entirely feasible and possible to reach a near complete follow-up, even in a population like in Bradford, which faces high level of deprivation, language barriers, and complex social needs. We also achieve good early reviews rates with 95% of infants seen at 3 to 5 months and near 100% of children were seen by 12 months. And hopefully that means that developmental concerns can be picked up much earlier, giving the children the best chance to access therapies and support at a time when it makes the most difference. So coming on to the outcome, so one of the interesting findings was that the difference between the tool we used. As you can see here, the Bailey 3 assessments, which are clinic-based and led by trained clinicians, tended to classify more children as average and picked up fewer severe delays. By contrast, the Parker R questionnaires, which are parent-reported, often identify more severe impairment and gave lower average scores. So why the discrepancy then? So we looked into it and we think there are several reasons. First, in a multilingual community like Bradford, language barriers make it harder for parents to interpret questionnaire, and bilingual children often acquire English more slowly, even if they are developing normally in their home language. And secondly, what we find is from speaking to families, not every family has access to the resources that were, asked in the questionnaire, which means that children, don't always get the chance to demonstrate the skills being asked about. And finally, self-reporting always carry more variability depending on how the parents perceive their child's progress. And I think one of the very important thing which I've touched on briefly earlier is many of the most severely affected children in our cohort were already under the care of the CDC team from the beginning, so they did not undergo the Bailey or Parker R. As a result, the Bailey and the Parker R cohort naturally represent the healthier end of the spectrum. So I think that was the reason why we thought that it's important for us to combine the data together to allow us to see, what is the actual developmental burden of our population. So you can see here, for cognition, around 39% of children had moderate to severe impairment. For motor outcome, about a quarter of the cohort show moderate to severe impairment, but the most striking finding was language. Nearly 45% of children had moderate to severe speech and language impairment, and this made it the most common area of difficulty across the cohort. And why is it important? I think it is very important because language development underpins so much of a child's later learning, social interaction, and school readiness. And the fact that almost half of our extremely preterm population is struggling in this area has profound implications for both healthcare and education services. When we compare our outcomes with published national data, such as the NNRD and the EPICURE2, our findings are fairly consistent. Our populations does carries a heavier developmental burden. Language delay is particular, in very common, and in Bradford, that burden is likely amplified by the additional pressures of deprivation and linguistic diversity, as I mentioned before. But there hasn't been much recent national outcome data. EPICURE2 was based on babies born in 2006, collecting data from birth in England of babies born between 22 and 26 weeks gestation. And the most recent NNRD analysis covers 2008 to 2018 infants born less than 30 weeks gestation. And I think that means that national picture does lags behind current practice and improvement in neonatal care. And as what we've heard from Dr. Oddie earlier, NNAP is exploring, ways of reporting developmental outcome, which I think will be very much welcomed. So I think local data sets like ours are becoming increasingly important, not only to guide service delivery in Bradford, but also to contribute to the bigger picture of what outcomes for preterm babies look like in the UK today. So knowing language impairment is by far the most common developmental difficulties, we use this information to look further into what we could do to improve this. And we noticed that there is a capacity gap in our speech and language therapy provision. The SALT service at present is not able to meet the demand in a timely way. That means that children are often waiting months for support, and those critical early windows for intervention are being missed. And they also are other, wider contextual factors as well, as you can see here on the screen. And I think this work has taught us, a few important lessons. I think first is, we learned that it can be time and resource consuming to look at all the data, but it is very much necessary. And without the integration of all the data, we would only have a fragmented picture of, the outcome of our babies. And especially if there are different tools being used like us at the beginning, the triangulation is even more important. And we also learned that, having a specific oversight makes a huge difference. when there is a dedicated named person or team who has an oversight of the NNAP data entry, for example, the accuracy improves and the data becomes more meaningful rather than just a tick box exercise. And finally, I think we find that the NNAP data can be a lever for change. Instead of treating it as an audit obligation, we use that to highlight gaps in provisions and to strengthen our case for commissioners. So looking ahead, we continue to build on our data. Our future directions is very much about broadening the scope, addressing inequalities, and using the outcome data as a tool for service improvement. We want to extend our follow-up beyond 2 years to school age. We want to link up with the early years foundation stage outcomes and to help us to understand how well the 2-year assessment predict later learning and educational progress. We also want to incorporate demographic and equality variables. By analyzing these factors, we can better understand inequalities and tailor service accordingly. And thirdly, we want to continue to benchmark against national data set. And finally, locally, we are working in partnership with our District Care Foundation Trust to strengthen our therapy pathways, particularly, as I've mentioned before, the speech and language therapy, and we're using this evidence to make a case for expanded provision. So this is the end of my presentation, and I want to thank my team. As you can see, their names are here on the screen. They have worked very hard to put the data together, and I want to thank the wider team as well for their support. Thank you.
Thanks so much, Aishin. And again, you've also finished bang on time. So there's quite a few different questions in the chat for you, so do have a look through those. But one of them in particular comes from the lovely Sarah Clark in Birmingham. And Sarah asks, do you have funded AHP support in the follow-up programme? I'd like to know what that looks like as well. At what points do your AHP colleagues input? And is there capacity in community services to offer AHP intervention? You mentioned a bit of a bottleneck in SLT, but what are the capacity issues are you seeing?
I think in Bradford, we are very grateful to have a good AHP provision. So we have 2 neonatal physiotherapists, we have OT, we have speech and language, we have dietitians as well. So I think what we see is our speech and language therapy, because the neonatal speech and language that we have are mainly providing the service for dysphagia, but actually what we see here in the data that I provided, the problem with the speech and language is the communication therapy that is lacking. So that is very much work that we need to work with the District Care Foundation, because the provision come from the District Care Foundation. So that is the main challenges that we see. But for the rest of the AHPs, I think from what we can see, especially for physiotherapists, the provision has been excellent and the babies have been seen timely.
Thanks very much, Aishin. There's definitely quite a few more questions in the chat, which I'm sure we might come back to during the Q&A session at the end, or feel free to have a look through them and respond to them as well. Thanks so much, Aishin. So we'll move on to our final speaker, but last but by no means least is the wonderful Humfrey Legge. Humfrey is a senior data analyst for the audits team at RCPCH. He is literally the NNAP guru. He is wonderful when he's definitely the most frequent responder to my stupid questions that I'll email in now and then. But his work on the data dashboards has been incredible. The work on the PAD and the RAD has massively transformed neonatal data, and that kind of near real-time access to data is really driving change. So Humfrey, over to you.
Thank you very much, Sarah. I'll just share my screen. hopefully you can see that now. Okay,
Yep,
so
we can see the RAD. Thanks, Humfrey.
fantastic. So today I'll talk about the restricted access dashboard you can see on the page here. Mainly I'll go over the expected use cases for the restricted access dashboard, how we hope it can help staff in units and networks. And then I will also look at some of the features of it and talk about how they might be used. And then finally, we'll look at a few of the new features that we will be releasing at the end of this week, hopefully. Before I talk about the RAD, though, I thought it would be helpful just to go quickly over the other two types of dashboard that we release, one of which Sam has already mentioned, which is NNAP Online. So we're aware it can be confusing having three different dashboards available. So we wanted just to talk through briefly what each of them do, and also just show you in the browser how you move between the three of them. So NNAP Online, as Sam has already said, is where we share our published results. So this is distinct from the other two dashboards, which I'll talk about, which show the most recent version of the data and the most recent version of the measures for each for that data. This just shows the results published in either the State of the Nation or the extended analysis reports for that particular year. And obviously, due to that, has some different features to the other dashboards. The main points of interest, I suppose, are that this contains the outlier graphs, and it also contains the treatment effects from the adjusted measures for the annual data. So that is a very quick overview of NNAP Online. The second I will talk about is what we call the public access dashboard, or the PAD. Here it's referred to as the frequent reporting dashboard. And you can access this through this link here. You could also Google it or find it through the college website. This dashboard is updated on a monthly basis, and it shows the most recent version of each of the measures and the most recent data that we have for each of those measures. It's restricted to 10 headline measures. And as it's publicly available, each of the data points here are they're rolling 1 year averages. So that's just a feature that we have to reduce a little bit the risk of deductive disclosure, because obviously we're releasing some of these data points are quite recently worked on. So you can see they're also highlighted, the more recent ones, as unassured data points. So that is the PAD, as we call it. And then if you want to look at the RAD, the easiest way to get there is through the PAD. You could also Google it. And this will not take me. This will, because I'm not signed in on this page, but you can see here how you would access. If you click there, it will take you to a sign-in page. And if you just enter your NHS email address, you will get access there, assuming that you have a user account. If you do not have a user account for the RAD, you can drop us an email and we can get one sorted for you. So this is the most recent version of the RAD. It is as yet unreleased, this version, and this one contains example data. So none of the data you'll see here is live. And I'll go through the features of it now. It is updated on a monthly basis. So on or about the 5th of every month, we'll release an updated version of this. It is obviously restricted access, as I've mentioned, so you need a user account to view it. And we have down here a little box saying when it was last updated. And here we have a change log that mentions changes that we've made to the dashboard on a monthly basis. And those do come in fairly regularly, so do keep an eye on it. If you're using it, you may see changes to the data. And if you do, and they're in previous months, the cause can be down here if we've made updates. We'll always let you know. Clicking through the pages, the first one to look at is the FAQ. This is only just briefly to say that we really welcome any questions or feedback, so please do drop us an email here if you have any. But if you have a question, it might be worth checking the FAQ first, because sometimes that's a bit quicker for you rather than waiting for us to reply. So please do take a look at these if you have any questions before emailing us. In terms of the time series data, just a little lag there. This looks a lot like the PAD, the public access data, and in fact these graphs are the same data, so they will have the same. These are all 12-month rolling periods. One of the differences in the restricted access dashboard is that you can change these rolling periods to be quarterly rolling periods, or you can even change them to represent the exact monthly proportions. And obviously, when monthly, you see much more variation in the data. One of the other features about the RAD, which is different, is that we have all the measures available rather than just the 10 headlines. And in this version, like I said, which we'll be releasing at the end of this week, we've also now put in the composite metrics, which previously weren't in the restricted access dashboard, but they are now in here. This line chart, you can also add a few additional lines for benchmarking. So you can add a line representing the average of units of the same type. In this case, that would be the NICUs listed down here. And that will come up as a little green line here. You can also add a network line for the unit. So in this case, it's Bradford, and the network would be Yorkshire. And then you can also add an ICS line as well for the ICS related to the unit that you've selected. And then we have gestational age breakdowns in the tiles underneath the main chart. The next tab shows the table data, which is going to be the exact same data as in the line chart, except it's obviously laid out in a table format. This tab also contains the newly input composite metrics, and then you can view down through here to see individual months if you'd like as well, and there are comparative proportions there as well. One of the new features that we will be releasing at the end of this week is the ethnicity data tab, which is completely new. And in this tab, you can select a particular measure, a unit. Most of the unit users will just have one unit available, and then you can select a whole data year from previous years or more recently, and a gestational age banding. And what it will show you is what the proportion of this metric or measure is for each of these ethnic groups. And you can also break down these ethnic groups into subgroups as well. We have that data too available, and we're going to be reporting a lot more on inequalities in future years. So ethnicity and deprivation. At the moment, we've just put ethnicity in. We'll be looking to add deprivation at a later stage. So we wanted units to be able to see what their data looks like if we're talking about national trends as well. And there's just a little comparative bar chart down here as well, which shows the unit selected compared to their network and the national rates. So that is the new ethnicity tab. The network data tab is of use mainly to network users, because unit users will only be able to see their unit, but network users can see all of the units in their network, and this is just an opportunity for them to do some comparison between different units in the same measure and their performance. We've made a very minor adjustment to this table, which was requested by some network users. You can now multi-select the periods, and this will allow you to do a download of this data, which will contain all of the years in one go. And I think this would be a good point just to quickly point out how to download data. If you click on the table and then follow the ellipsis, the export data button, hopefully you can see the pop-up. And then if you select summarize data and CSV, the export button will appear. And that's possible for any of the data tables in this report. though the network users can see this, they are not able to see the patient list, which is exclusively for unit level users. And this is an area where we hope it's helpful for users to see in advance of any results, how their results are being classified for each particular episode. So in the live version, this will be the Badgernet episode ID down here, and you will have, you'll be able to select any, run these filters to specify this table to show exactly what you want. There's really two ways we expect users to use this, although you can use it however you'd like, obviously. The first is exploring missing data. So if you were to select a year that you want to look at missing data for, you can find 2024. And if you just filter by missing and select all of the measures, this will give you a list of all of the episodes that have missing data for this year. And that could be something that you could use and go through just to cross off to make sure there is no missing data, or as little as possible for your unit for a particular year. The other way that you might want to use it is to look for patterns of non-adherence in some of your patients using the Details tab. So if we were to look, for example, at temperature and select non-adherent patients, you can see not just a list of non-adherent patients, but the reasons why they've been classified as non-adherent in the NNAP. And these results should come out exactly as we'll run the analysis for the annual reports. So hopefully that is helpful for you. Very quickly, just to go onto the last tab, which is the user list. This is a tab which offers users the opportunity to see every other user that can access their unit on networks data. And we would encourage users to go on here once in a while and just make sure that everyone that they expect has access to their data does have it, and anyone that's moved on from their unit no longer has access. And that is the end of my very brief tour of the restricted access dashboard. Happy to answer any questions.
No obvious questions. Oh, wait, yes, I'm so sorry. Can we download data only for a unit and put them in slides?
Yes, definitely you can download data for your units. If you're talking about the table data, that would just be using the ellipsis and downloading that data. Downloading images is more tricky. I would expect the easiest way to do that is to do a screenshot of the graphs, and we've put on dynamic headers for those graphs, which should make it a bit easier. So you shouldn't have to add extra context to them. Yes,
I've been usually using screenshots, Humfrey, but the concept of the table download is fantastic. Thank you so much. Do pop any. Oh, there's just another question popped in from Shalini. Would it be possible to have a PDF guide or downloadable video of these instructions to share with our local team?
Yes, I think we are looking forward to hopefully creating soon a video guide for the restricted access dashboard. There are details on how to use it on the landing page for the restricted access dashboard on the college website, but I appreciate they're maybe not completely comprehensive. So it'll be somewhere between the FAQ and the video guide that we'll be releasing hopefully quite soon.
Brilliant.
Hopefully there's a question about how quick, if I edit some data in Bradford's RAD today, in Badger today, how quickly will it feature in the RAD?
So we update the RAD for all previous years and all measures on or around the 5th of every month. So it's probably the first working day after the 5th. So if you enter data on any day, by the 5th of the following month, it should have been updated and it should be represented in the new version. And you can check that box in the bottom left-hand corner of the RAD to see when it was last updated, and that'll give you an idea.
And there's also loads and loads of comments saying, thank you for this. This is brilliant. Thank you. Great presentation. Awesome. So just lots of love for Humfrey and the RAD in the chat for sure. And I think you were mentioning that the ethnicity data will become available soon. Do we know roughly when? I don't want to pin you down to a date, Humfrey.
Yeah, we were hoping to get that out before this presentation, but the quality assurance of it sadly took a little longer, and we wanted to obviously make sure it's coming out exactly as intended. So we're hopeful that should be by the end of this week.
Great. That's fantastic. So with 1 minute to spare, we can move on to the general Q&A session. Sam, do you want to pick a topic that's caught your attention in the chat first?
There's lots of really good questions, but keep them coming. So I realised there's two things that I could have made clearer in talking about NNAP. One is that the posters. So I referred to the posters, and various people tell me that they really like the posters and they think they're a good thing. We hope that nobody downloaded the posters before Tuesday lunchtime. Have I got the time wrong, Humfrey? Yeah, nod. Because we made a correction on Tuesday lunchtime.
Monday, I think, Sam.
Oh, I'm sorry, Monday lunchtime. So thank you very much to the person who pointed out that we'd made a clerical error there. So if in the event that you downloaded your poster from NNAP Online between Thursday and Monday lunchtime, please would you mind printing it again? But those of you who haven't done it, and that includes my unit, we'll be printing it out today, and it will be correct. So that's one thing I failed to communicate. The other thing that I failed to communicate adequately, judging by the questions, is how we chose what to analyse for the disparity work that I showed you. The disparity work is based on care processes, and it's not analysing outcomes. So we haven't, for example, described the relative rates of NEC or bloodstream infection or preterm brain injury, or as the question that Lawrence asked, death by ethnicity and deprivation. The reason we haven't done that is because, well, for a variety of reasons, it's significantly more complicated to do well, and we want to try and do these things well. And also, it's a little bit more straightforward to action your DCC rate than it is to action your death rate or your bloodstream infection rate. So for that reason, we don't have a current plan, Lawrence, to include the rates of outcomes by ethnicity. But we also don't have a plan currently to release them by deprivation. And the reason for doing that, focusing on ethnicity, was you've got to choose something. I thought if we chose both, it would just be too much and it would confuse the message. I think it is very surprising what we see. I'll say one more thing about the disparity work. Not sure if I made this sufficiently clear. It seems to us that at least some of the disparities are mediated by centre effects. So that minoritized ethnicity groups are cared for in units that aren't doing these care processes as well as national average. And it was for that reason that I said the first thing units should do is compare their rates of, say, DCC to the national average, and only then look for local ethnicity disparity. So I hope that makes sense. If it doesn't, I really have to have another go at trying to explain what I think I mean. So that flowed from a question. Happy to take others. It's really exciting, the chat.
Thank you, Sam. Looking back at the early part of the chat, which related to the data around BPD outcomes and non-invasive ventilation, there's two questions from Wales, from the opposite parts of Wales, and slightly differing questions, but on that same topic. So from Glenclwyd in North Wales, there's a question around whether NNAP is able to relate the rates of BPD to the units with higher rates of babies receiving only non-invasive ventilation in the first 7 days of life. So that's one part of the question around NIV and BPD, and I'll come back to part two from South Wales in a minute.
Oh, brilliant. Thank you. I was afraid you were going to ask two questions and I'd forget the second one. So the answer is we did do a scatter plot of that in last year's extended analysis report. I'm fairly sure that it's in the report. There isn't an obvious relationship, but that does not mean that there isn't a relationship. Comparing centre a scatter plot of centre achievement on those two audit measures isn't really the right way to answer that question. So this is a rich area for potential research, and we're really enthusiastic about doing the right bits of work with the right partners. And I've tried to indicate that we've done some of that already. So really happy to think about answering the right questions. We have limited capacity to do that, so it has to fit with the audit work, but it's not impossible to address questions. And the second one was
so that's from Lucy Perkins in Swansea in South Wales, and it's around whether we should be excluding 22 and 23 weekers from the analysis around non-invasive ventilation. Lucy's interpretation being that that intubation is recommended for the nano preterms, and therefore shouldn't we be excluding them? But I'm aware there's definitely widely differing practice around different NICs in the country. So over to you, Sam.
Thanks, Lucy. I actually agree with you about 22 and probably 23 weekers. I tried to download the measures guide, but my trust said I wasn't allowed to do that because it's got a big brother watching over me. And I'm looking at Humfrey to see if he can remember the measures guide, the inclusion criteria for that, because I can't. What I will say is that the number of 22 and 23 weekers is tiny compared to, thank you, Lucy, I see what you say in the chat, which says it's all under 32 weeks. I think the number of 22 and 23 weeks is tiny, and so I don't think that that's really the kind of key focus of the measure. What we're trying to do is to make people think about the extent to which they use non-invasive breathing support compared to other units that are similar. And I think as often in NNAP, it's a good idea to choose the unit to compare yourself to. So my own unit has much in common with, say, Middlesbrough. It's about the same size, comparable demographics in some ways, and doesn't have an on-site surgical service. So there's something for me about picking who to compare yourself to. Obviously, we compare ourselves to Leeds all the time because they're just next door and that's a bit of fun. But there's something about making valid comparisons. I don't think we could consider that. We could take it to the methadone data set group, but it doesn't seem core to the measure to me. Thanks for the question.
Thanks so much. I think one of the next one that sparked quite a lot of debate in the chat was whether we should have exclusion criteria for the delayed cord clamping measure based upon the infants that require resuscitation. You won't be surprised to hear that I've definitely got thoughts on that, but I'll let others answer first.
Sarah and others. So we've discussed this often before. So I think so the version of the question I've seen comes from a non-clinical colleague. The challenge with that, was it Duncan? I can't remember if I got your name, but is knowing how to robustly define the patient who needs resuscitation. So what is in my own unit, for better or for worse, we do not do cord intact stabilization. So we don't do any active resuscitation of the baby. Some people like to say on the cord, as in before cutting the cord. So we don't exactly leave the baby alone. We keep a close eye on them, but we don't actively do anything to them. If the clinical assessment is such that we think we need to do something, then we clamp the cord and move the baby to the resuscitator and do it there. Now, we've got to very high rates of deferred cord clamping. So I think that what that illustrates is that if you don't do something, you just stand there, then you very often don't need to intervene. And that there is clearly a move. Well, no, there isn't a move. That's exaggeration. There's going to be a trial, I understand. There's a proposal for a trial, certainly, for a trial whereby the baby who is perceived to require resuscitation will either be randomized to get it or not at centre level. That's a very exciting prospect if that trial comes off, which I think it will. And that will then answer the question as to whether cord intact stabilization is the right thing to do or not. But what I would say as a long-standing advocate of deferred cord clamping is we shouldn't let a thought that cord intact stabilization is the right thing to do get in the way of implementing deferred cord clamping. Very high rates of deferred cord clamping can be achieved without cord intact stabilization. Long answer, short question, apologies.
I think you're right, Sam, that there are definitely centres where not doing cord intact stabilisation, but just having a very pro-DCC approach, you can achieve high rates. But there are other centres where not being able to get hands on the baby is a barrier to DCC. And definitely that's been a barrier reported in quite a lot of centres, especially where they see preterm babies less frequently and they're more inclined to feel that that baby needs resuscitation, because I totally agree with you that that can be very subjective, that requirement for resuscitation. And so for many of those centres, the ability to at least be able to begin providing thermal care, some stimulation and the initial assessment with the cord intact has been a great way to move towards higher rates of delayed cord clamping. So I think it can vary at centre level for sure. Were there other questions that the speakers have seen in the chat that they'd really like to respond to? Any particular topics? Otherwise, I'm just going through in order and just picking different topics. So do shout up if there's questions that you've...
So I don't know whether Aishin's still with us. She is. She's just turned the camera on. So there's a question about early identification of infant presentation of autism. And we could maybe pick that. There was another question about, did you want to say anything about that question?
Yeah, I think I have replied in the chat to say that, you know, this is definitely an area that we are seeing more, that a lot of the global developmental delays could be a first sign of ASD. But I think at 2 years old, it's still too early for for anyone to confidently say that this is definitely ASD. So what we do is, you know, when I do a 2-year assessment, I also write an extensive written report on other things that I see that are probably not being picked up on the actual Bailey assessment. So, you know, like, you know, their attention, you know, how their eye contacts are, whether there's any pathological signs or abnormal play that the children have demonstrated, and that is included in my report. And I will make suggestion to my colleagues to make a referral to the CDC, and you know, the report that I have written hopefully will be useful when it comes to you know, making onward referral for neurodiversity assessment.
Can I come in? There's there was a question about measuring severe disability. I think somebody said that Badger defines severe disability as more than 12 months delay. So I tried to hint that that NNAP aspire to describe the proportion of babies of less than 30 weeks gestation attributed to a centre that have severe disability. The way that we're going to do that is going to horrify my wise and sophisticated developmental colleagues such as Dr. Lok, although of course I have discussed this with her, and that is to use a very crude classification system, namely the Oxford minimum data set. That is, to those of us who are more Badger orientated, the questions that you get asked at 2-year follow-up in Badger allows you to very crudely put babies into groups of severely disability or not. There's a validation paper of that that we've it's previously been used, and we planned to explore whether we can do that, which I think we can, and I think that will be a step in the right direction. I also think it will reward centres who achieve very high levels of follow-up, such as we have in Bradford under Dr. Lok's leadership, and I hope it will make it sort of seem worthwhile to centres. Yeah, we've got done our follow-up, and the reward, the output is that we're able to say what's happened to our babies. So I think it's shocking, really, that in the 21 years I've been in Bradford, we haven't actually been able to say how the children get on until my excellent colleague Dr. Lok rocked up. And so, you know, it's not great, really. we ought to have been able to do better, and I'm grateful to her for making it happen.
Thank you so much, Sam. One of the other points in the chat that you mentioned you'd like to bring up in the discussion is around whether we should be extending the length of time limit for the admission temperature to allow greater contact for those later preterms. And having been part of both project board and methodology and dataset group, this is a long and hotly debated topic. So what do you think the current views on this are?
So Sarah, you've been excellently chairing. There's another question which actually points in the opposite direction, which kind of illustrates the challenge of this area. So somebody else asked, why have we left out the, or at least I understood the question to be, why have we left out the 34 weekers? The challenge is, if the measure is hard to, this is an oversimplification, but I hope it's illustrative. If the measure is hard to achieve, should we change the measure? And I think that there is a good reason not to do that. So there is national guidance which says that for babies that are less than 34 weeks, you should admit them to the NNAP unit directly after they're born. Now, and that's the BAPO national guidance. There is, of course, logic to letting the mum hold the baby, but to get the baby into the neonatal within an hour of birth is, I think, very much adherent to what the national guidance is saying in black and white, but also sort of more importantly meaning. The reason we haven't changed to having some other measure of thermoregulation is because we think there's one thing that can be measured, and there's been the admission temperature is a well recognized. We still get a fair amount of do you really mean that by admission temperature kind of conversation? But I think most people think they understand what an admission temperature is. One of the real challenges in this, speaking from experience of local quality improvement, is there's a bit of a tendency to pick the best temperature. And if we have a whole series of temperatures associated with the baby, that there's a real risk that the measure will be gamed and will become less meaningful as a consequence. So I absolutely accept that deliver and cuddle is a sensible, compassionate, reasonable thing to do in some circumstances. I don't think it necessarily interferes with this, and there is the relevant national guidance. I hope that's an answer to the question. It might be one you agree with. I see Kirstin's got a hand up.
Yeah, I just thought, Sam, this might be an opportunity to point out that this is something, if we are, where we're aiming to link maternity and neonatal data, that it's those late pretermers, the 34 weeks onwards, who may not go into the neonatal unit and stay with mum. And, different units have different setups for transitional care and such. And so these early measures of postnatal care under maternity services, blood glucose, temperature, these sorts of things are something that perhaps, we can look to be reporting in the maternity data going forwards. And that's something that we've talked about picking up, and how that looks like at the moment, we don't know because of the data quality, but until we start asking and looking at these things, we can't improve them. So.
Absolutely, Kirstin. And do you anticipate that there's going to be differences as well in the delayed cord clamping measurement? How do you think that might work? Sorry,
Yes.
Sam, if I interrupted you. I'll definitely come back to you after that.
It's a really interesting, particularly delayed cord or time to cord clamping is an example that I often use. So in the neonatal world, I think we don't realise how lucky we are with how few EPRs we have, or patient records. We have Badgernet, and then some units use Cerner and Epic. There are almost 20 different IT providers in the maternity world. So and even though there are data standards, they all record things slightly differently. So particularly cord clamping, there is the time in minutes and seconds from birth when the cord was clamped. There is the time on the clock for when the cord is clamped. There is was cord clamping less than a minute, more than a minute, more than 3 minutes. So there's all these different ways of recording it. So how we're going to bring that together to actually report it in the maternity world is currently a conundrum.
Thanks, Kirstin. Sam, back to you.
So I've already forgot what I was going to say previously. It's absolutely fine, because what Kirstin says is really important. And it's a nice illustration of why we need a neonatal information standard, an NHS-owned neonatal information standard. So if we use something even more basic than the time of deferred cord clamping that Kirstin referred to, just say birth weight. Now, we all know what we mean by birth weight. Some of us want to measure it in kilograms. Most of us want to measure it in grams. So we basically need there to be an information standard that actually specific needs to be neonatal, not perinatal, because there's an overlap to be managed with maternity. We need NHS England to and the devolved governments to own this process and to define, and then in time, under the 2022 Act, the EPR providers are legally obliged to make their information systems collect, in my example, birth weight, in Kirstin's example, deferred time of cord clamping, in relation to a standardized way. So in my example, in my world, that'll be grams, but grams or kilograms doesn't matter. In Kirstin's, we'll agree when time zero is and when time of cord clamping, and that's the information that we'll collect. It's not impossible, but there is more to do. And it's not actually a huge piece of work, but there is now agreement that needs to take place. So I think that's very exciting. I'm sorry, we're walled on. So much to talk about.
So I think we're near the end of the webinar, Sam, but perhaps that just leads us into one final comment. There's quite a few comments in the chat and a lot of concern across the country around the different changes in EPR providers and the impact on different units and NNAP data. Any final thoughts on that, Jem?
Not from me, except to thank you, Chair, and all of the attendees for coming and joining. We're super happy to pick up correspondence with you. We can stay on the chat if anyone wants to continue to do that. But I'm aware that people may need to rapidly drop off. So just thank you very much, Sarah, for chairing, and I'll shut up. But please do write to us.
Lots of lovely comments in the chat, thanking everyone. So thank you very much to all of the speakers. Thanks, Humfrey, Aishin, Kirstin, and obviously Sam, and to the NNAP team for masses of work every day of the year to make it possible for us to try and improve neonatal care for babies and their families. Thank you all very much.